In this section, we're going to talk about AV blocks. This is a situation wherein there is either a delay in the conduction of electrical impulses through the AV node or a complete cessation or blockage of the impulse transmission from the AV node to the ventricles. This will result in disorders that will be manifested by the PR interval. If we recall, the PR interval reflects the time that it takes from an impulse to travel from the atria all the way to the AV node before ventricular contraction. Let's trace an electrical impulse from its generation from the sinus node all the way to the Purkinje fibers. So an impulse is generated from the sinus node. It travels to the atria through the internodal tracts as well as the Bachmann's bundle, and it travels to the AV node, and from there it proceeds through the bundle of His and to the bundle of branches. Now, in AV blocks, what's going to happen is that there's going to be a condition wherein the AV node is unable to transmit electrical impulses in its normal fashion. This will be reflected by changes in the PR interval. So the hallmark of an AV block is going to be alterations in the PR interval. And AV blocks are going to be classified according to degrees, with obviously the least dangerous being a first degree and the most dangerous being a third degree heart block. The classifications of AV blocks according to degrees are first degree AV block and second degree AV block, which actually are two types, Mobitz 1 and Mobitz 2, or type 1 or type 2 AV block, and lastly a third degree AV block. Now let's take a look at each one of these blocks and look at their characteristics and note how they are differentiated. In a first-degree AV block, there is a delay of the transmission of electrical impulses from the atria through the AV node. As you recall, the normal PR interval should be 0.12 to 0.20 seconds. When it exceeds 0.20 seconds, this is a manifestation that the AV node is incompetent in conducting the electrical impulses through the AV node all the way to the ventricles. Therefore, it results in a prolonged PR interval. Let's suppose that an electrical impulse was generated by the sinus node. It travels through the atria, through the internodal tracts as well as the Bachmann's bundle, and then the electrical impulse finally arrives at the AV node and it tries to conduct the electrical impulse through it. In a normal fashion, this should take approximately 0.12 to 0.20 seconds. This is the normal transit time from an impulse in the atria to traverse the AV node. Now, when the AV node is sick, then the transmission of electrical impulses will not be as efficient. This is a first-degree AV block. The other properties of a first-degree AV block are, number one, all the PR intervals should be the same. And number two, since the conduction of electrical impulses remains to be intact through the bundle of His and the bundle branches, the QRS complex will be normal. Here are the other criteria for the ECG characteristics of a first-degree AV block. First-degree AV block is a benign rhythm. It usually is as a result of myocardial infarction, or perhaps it might be due to certain drug effects as well as hyperkalemia and other electrolyte disturbances. If this were the sinus node and it fired and it traverses through the atria and it reaches the AV node right over here, and then from the AV node to the bundle of His and onto the bundle branches, the transit time from the sinus node initiation of electrical impulse all the way to the AV node is supposed to be in a period of 0.12 to 0.20 seconds. The transmission of electrical impulse in a first-degree AV block is similar to this, except for the fact that the movement of the electrical impulse is going to be delayed. So from the sinus node to the atria and onto the AV node, or before the AV node, is normal. But as it goes into the AV node, there is a significant delay in the transmission of electrical impulses. The delay is in the AV node, and the PR interval will reflect this particular delay, and therefore the PR interval is going to be more than 0.20 seconds in a first degree AV block. It must be noted that all the impulses are going to be transmitted similarly through the AV node. So if the AV node or the PR interval is going to be 0.22, it will be 0.22 for all the beats. All the PR intervals will be consistent in a first degree AV block. Let's analyze an example of a first-degree AV block in an electrocardiogram. In this particular strip, the rhythm appears to be regular. So let's go ahead and use our caliper, and it looks like it is regular. Yes, it's regular. And the rate is 1, 2, 3, 4, 5, 6, 7, 8. It's 80. And the P waves are all present. They're all look alike, and they're upright. And so let's take a look at the PR interval. The PR interval looks the same throughout, and the PR interval is 1, 2, 3, 4, 5, 6, 7, 8, around 8 boxes. So we measured the PR interval and it's prolonged. This is a characteristic of a first degree AV block. Alright, let's measure the QRS complex, and it looks like it's narrow, it's normal, and it is around 2 boxes, 0.08 seconds. So it's normal. So the analysis of this strip is that the P wave was transmitted through the AV node in a delayed fashion, longer than 0.20 seconds. The transmission was consistent, and so this is a hallmark of a first-degree AV block. In summary, our findings are: the rhythm is regular, the rate is 80, P waves are present and normal, the PR interval is prolonged and consistent, the QRS is normal, the rhythm interpretation is a normal sinus rhythm with a first-degree AV block. The next type of block is second-degree AV block Mobitz 1 or Type 1, also referred to as AV Wenckebach, in honor of the physician that described this electrocardiographic phenomenon. In a second-degree AV block Mobitz 1, most of the impulses are going to be transmitted through the ventricles, but there's going to be a gradual prolongation of the PR interval. Each successive PR interval will be greater than the former, and until such time that the AV node is no longer able to conduct the electrical impulses. I'd like to liken this to somebody who works on Monday and has a lot of energy. On Tuesday, is getting a little bit tired. On Thursday, more tired. And on Saturday, can no longer go to work. And so it's similar to the pattern of conduction through the AV node in this particular type of AV block. Let us look at the electrocardiographic manifestation of this particular rhythm. So let's say now that the sinus node fires an electrical impulse. It goes to the AV node, and it goes to the bundle of His and to the bundle of branches, and it might be therefore transmitted with a normal PR interval. So let's say now that this PR interval was 0.18. Now the second sinus beat might be produced again, and it goes into the AV node. But as it traverses the AV node, it takes a little bit longer to do so, and therefore the PR interval is going to be prolonged. So you would still have a P wave with a PR interval that is actually successively longer than the previous PR interval. So this might be a PR interval of 0.22. And maybe the sinus node again fires, and it goes into the AV node, and this time it travels through the AV node much slower than the previous ones. And so the PR interval might eventually be around 0.28 seconds. And let's say now that the sinus node fires again, but the AV node this time is not able to transmit the electrical impulses. So therefore, it results in a P wave without a QRS complex. So whenever you have a P wave without without the QRS complex. This therefore is termed a block, meaning to say that the electrical impulse was blocked from moving from the atria all the way to the ventricles. This therefore results in a P wave without the QRS complex. Such is a pattern of what happens in this type of AV block. Let's take a look at an example of an electrocardiogram which demonstrates this gradual prolongation or the successive prolongation of the PR interval until such time that a P wave is no longer conducted through the AV node. So when we take a look at this electrocardiogram, we know that the rhythm is irregular. It is irregular because of the pause that you can see in the middle. And let's go ahead and illustrate that. So if this is the QRS complex over there, it is regular over here until such time that there is a beat that is supposed to be scheduled to occur over here, but it didn't happen. So it is irregular. The rate is 1, 2, 3, 4, 5, 50. And the P waves are present except for one P wave right over here, wherein we see that it is not partnered. We all know that all P waves is supposed to have or to be followed by a QRS complex, but in this particular P wave, there is no QRS complex. So when we see a P wave without a QRS complex, we said that it should be identified as a blocked P wave. So there's a blocked P wave, which means to say that the P wave or the impulse coming from the atria was not successful in being conducted to the ventricles, resulting therefore in a P wave without a QRS complex. So this is the most significant observation that you will see, or the first observation that you will see in a second degree AV block. There is a P wave that does not have a QRS complex. When we take a look at this, we'll look at the PR interval. So the PR interval, as we could see, we're going to measure it from this, and maybe this PR interval is going to be, let's say, around 0.20 seconds. And the next one, however, is no longer 0.20 seconds, but it's a little bit longer than that. And so let's take a look at it. It is around 8 boxes. And the next one is going to be even longer than that. And it looks like it is 9 boxes. And then we go to the next one, and it is even longer. And this time it's 12 boxes. So as you could see, there's a gradual prolongation of that PR interval. Following the pause, following the P wave that is not conducted, there should be a shortening of the PR interval again. And it is. It shortens and then gradually increases in its duration once again. As you could see, there is a grouping of beats. Whenever you see a grouping of beats separated by a pause or a P wave without a QRS complex, be very suspicious that this is a second degree AV block type 1 or Mobitz 1. Alright, so let's measure the QRS complex. The QRS complex is normal, looks like it's narrow, and let's see, it's around 1 box, 0.04 seconds, and they're all the same. So the QRS is normal. Mobitz 1 may be confused with a non-conducted PAC, something we discussed earlier in the atrial module. The reason why it's easy to confuse the two is because both have a P wave without a QRS complex. It's important that when you see a P wave without a QRS complex, that you're aware that there is a difference between Mobitz 1 and a non-conducted PAC. So let's take a look at the differentiation of the two rhythms. If you take a look at the CCG, both of them have a P wave that does not have a QRS complex. Let's begin with the Mobitz 1. So we all know that in Mobitz 1, there is a P wave that is not conducted all the way to the ventricles, and therefore it results in a P wave that does not have a QRS complex. But look at the behavior of the PR interval in this particular strip, the PR interval gradually prolongs until such time that the P wave is no longer conducted. In Mobitz 1, the P to P intervals are going to be the same. In other words, the sinus node fires regularly, and let's illustrate that point. Now, if I were to put my caliper from one P wave to the next P wave, notice now that it will be consistent. It will always be occurring at the same time. And contrast that now to what we have when we have a premature atrial contraction that is not conducted. So notice now that the P to P interval in a non-conducted PAC is going to be this way, okay? So it's also regular. But the P wave that is not conducted is going to be premature or early. And in addition to that, early P wave is different in morphology or configuration than the other P waves. So the basic differences between a non-conducted PAC and Mobitz 1 is that the P to P regularity is going to be unchanged, or the P wave occurs on time in Mobitz 1. In a non-conducted PAC, the P to P regularity is interrupted, and the P wave is one that is observed to occur prematurely. In addition to that, the P wave without a QRS complex, if you look at it, in a Mobitz 1, the P wave morphology is going to be the same as the previous P waves. In a non-conducted PAC, the P wave without a QRS complex is going to be different from the rest of the P wave. And lastly, the PR interval of the basic rhythm in Mobitz type 1 is going to gradually prolong, whereas in a non-conducted PAC, the PR interval of the basic rhythm remains constant. Such is the differentiation of a premature atrial contraction from Mobitz type 1. This underscores the importance that whenever you see a P wave without a QRS complex, you need to ask yourself, is the P wave the same as the other P waves, or is it different from the rest of the P waves? And in addition to that, the PR interval in Mobitz type 1 will gradually prolong, whereas in a non-conducted PAC, the PR intervals will remain constant or the same. Mobitz 1, or second-degree AV block type 1, is a benign rhythm. It usually follows acute inferior wall myocardial infarction because of the decrease in the blood supply to the AV node, causing ischemia. Other causes may be as a result of side effects of drugs, particularly beta blockers, calcium channel blockers, and digitalis. Electrolyte disturbances such as hyperkalemia may also cause a second-degree AV block type 1. Patients with second-degree AV block type 1 are usually asymptomatic, and the reason for this is because the cardiac output oftentimes remain within normal range. The ventricular rate oftentimes is within normal, and thus cardiac output is preserved. However, in some instances, if the heart rate is going to be slow, then we should treat the heart rate. But in general, Mobitz type 1 is a benign rhythm. The next type of AV block is second-degree AV block Mobitz or type 2. This is a less common AV block compared to Mobitz 1. However, it is much more serious. As you could see, the reason why it's much more serious is because there are more P waves that are not conducted to the ventricles, leading therefore a potential for a decrease in cardiac output. Second-degree AV block type 2 has the potential to progressing to a more serious rhythm, and that would be a third-degree AV block or ventricular standstill. And the worst part of that is it could occur without any warning. Second-degree AV block is a major complication of myocardial infarction, in particular anterior wall MI. Other causes may include myocarditis or perhaps a degeneration of the electrical conduction system, as may be seen in the elderly. In the event that the cardiac output is decreased because of the many P waves that are not being conducted to the ventricles, this might have a potential for causing a syncopal episode, and this is what is known as a Stokes-Adams attack. So let's take a look at the characteristics of a second-degree AV block as far as its electrocardiographic manifestation. In this ECG strip, we will look at the ECG characteristics of the second-degree AV block, Mobitz or type 2. If you notice that in this type of block, there are more P waves that are not being conducted, and therefore numerous P waves without QRS complexes are going to be noted. The characteristics of a second-degree AV block are the following. The rhythm. The rhythm could be regular or irregular. The rate is variable. It could happen in any rate, but usually with the many P waves without QRS complexes, it will result in a slow rhythm. P waves. There will be many P waves or more P waves that do not have QRS complexes. And depending on the pattern that exists, there might be a specific ratio between P waves and QRS complexes. The PR intervals. This is one thing that is going to be a very critical observation leading to the diagnosis of second-degree AV block type 2, because the PR intervals are going to be fixed. They do not change from one to another. The PR intervals are consistent or remain the same. The QRS complex is normal, and these are the characteristics of a second-degree AV block type 2. Let's discuss this ECG first. Rhythm. Let's take up the R to R interval is, as you could see, regular. The P to P intervals are going to be regular as well. And therefore, the atrial rate is not going to be the same as the ventricular rate. The rate. In this strip, the rate is 40. It is slow. P waves. As you could see, there are P waves without QRS complexes, which gives us an indication that there is an AV block. The PR interval. The PR intervals are fixed. Let's take a look with our measuring device. Note that this PR is going to be the same as this PR interval right here. They are consistent or they are the same. This is the hallmark of a second-degree AV block type 2. There is a fixed PR interval. And in here, the measurement of our PR interval is around 0.16 seconds. The QRS is normal, so let's go ahead and measure our QRS complex. Our QRS is going to be around 0.10 seconds, and it is normal. The characteristics of a second-degree AV block are the following. Rhythm is going to be regular or irregular, depending on the ratio of P waves to QRS complexes. In this particular strip, we see that there are 3 P waves for 1 QRS complex, leading to 3:1 conduction ratio and maintaining a regular rhythm. The rate is slow, which gives us a clue that this is a more dangerous rhythm because it has the potential for decreasing the cardiac output to a large extent. P waves. The P waves are present, but many P waves do not have a QRS complex, and therefore there is a block. The PR interval. The PR intervals are all the same. They're fixed, and this is the hallmark of a second-degree AV block type 2. The QRS complex is normal in this particular instance. Although second-degree AV block is less common than Mobitz 1, it is a more serious rhythm. Mobitz 2 is going to be serious because it leads to a decrease in the heart rate. And slowing down of the heart rate usually will also mean that there is going to be a decrease in cardiac output. If the patient develops symptoms of hypotension, or perhaps chest pain, syncope, or maybe shortness of breath, then this indicates that the patient is not tolerating the rhythm well. Treatment of Mobitz 2 includes pacemaker insertion. Thus, if you notice Mobitz 2 on the monitor, you must observe the patient and you must also notify the physician because there is a need for external pacing or an internal pacing to be commenced. External pacing can be used as a temporary treatment treatment while transvenous pacing is being readied. Atropine is never used in this type of rhythm because it would cause a worsening of the AV block. In the event that Mobitz 2 is not resolved, then a permanent pacemaker is usually indicated. Third-degree AV block is the most serious of all the AV blocks. It is also known as a complete heart block. Let me illustrate what happens in a third degree. So let's suppose that this is the AV node, and this is the bundle of His, and then on to the bundle branches. In a complete heart block or third-degree AV block, the AV node is unable to transmit electrical impulses at all into the ventricles. This results in a dyssynchrony or the loss of continuity of an electrical impulse traveling from the sinus node all the way to the ventricles. Let's suppose that the sinus node fires an impulse. The sinus node fires, but the impulse cannot go past the AV node. So what can happen? Well, what can happen is that the ventricles, which has a automaticity rate of 20 to 40 beats per minute, can generate an electrical impulse at that rate and therefore cause a QRS complex. However, this QRS complex is not going to be the result of the electrical impulse that originated from the SA node. So this P wave did not cause the QRS complex below. It will result therefore in different rates because the sinus node has a potential for 60 to 100 beats per minute, whereas the ventricles have a potential for generating electrical impulses at a much slower rate of 20 to 40. So one of the characteristics that you will see is that the atrial rate is going to be different from the ventricular rate. The difference between these rates is what is termed AV dissociation. In other words, the atria is having its own activity dissociated from the ventricular activity. The sinus node continues to fire at 60 to 100 beats per minute. The ventricles fire at 20 to 40 beats per minute. And this results in a dissociation. The QRS complex could either be narrow or wide. It is narrow if the impulse coming from the ventricles come from this area of the bundle of His, because it could still proceed naturally or normally into the right bundle and the left bundle. However, complete heart block could also be manifested with a wide QRS complex. In the event that the electrical impulse are going to originate from the ventricles itself, then what's going to happen is that there's going to be a movement of electricity through the ventricular muscle mass, and this is going to be a slow process. It could produce a wide QRS complex. So the QRS complex in a third degree heart block may be normal, as I had explained, or it could be wide. And generally, when it's wide, it usually is going to be slower in its rate. And the wider the QRS complex, the more evidence there is that the ventricles are generating the electrical impulse. P waves and the QRS complexes do not have any relationship, and thus it results sometimes in P waves being swallowed, so to speak, by the QRS complex. So what I mean by that is, if this is a P wave and a QRS occurs without synchrony to the P wave, what's going to happen is you might see P waves that are half into the QRS complex. This is a very classic finding in third degree AV block. This is an ECG strip demonstrating complete heart block or third degree heart block. Let's go ahead and examine its characteristics. Rhythm. The rhythm is regular in this strip. Rate. The rate is 40. It's slow. P waves. There are P waves that do not have QRS complexes, and therefore this is an indication that there is an AV block. So let's take a look and mark at all the P waves. There is a P wave, another P wave over here, another P wave probably in the QRS complex. This is another P wave, and another P wave again buried in the QRS complex. And so we see that the P waves that are coming at a regular rate, the QRS is also coming in a regular rate. So the atrial rate is regular, the ventricular rate is also regular, but the rates are quite different. The ventricular rate in here is 40, whereas the P wave rate, as we could see, is, that's 5, 10, 15, 20, 21, 22, 23, 24. The atrial rate is 63. P waves, many P waves, are not followed by a QRS complex, and therefore there is a block. PR intervals. If we look at the PR intervals and measure them, this is what we get. Notice now that the first PR interval is not the same as the second PR interval, and even the third PR interval. There is wide variability, and this is an indication that there is dissociation between the atria and the ventricles. Atrial contraction is not causing ventricular contraction. QRS complex. Let's measure the QRS. The QRS complex is 3 boxes, so it's abnormal. It's 0.12 seconds. So the characteristics of a third-degree AV block are rhythm. The rhythm may be regular or irregular. The atrial rate is going to be regular, and the ventricular rate will also be regular. The P wave rate will be different from the ventricular rate. P waves. There will be several P waves without a QRS complex. PR interval. The PR intervals are going to be variable. QRS. The QRS may be normal if the block is located in the bundle of His, or it could be wide if the block is located at the level of the bundle branches. This is another example of a third-degree AV block. The reason I wanted to demonstrate this particular strip is because it shows second to the last and the last QRS complex. It shows you that there is a P wave that is half buried within the QRS complex. This is a very classic sign that there is this association between atrial activity and ventricular activity. And that is why this particular appearance of the P wave seemingly being buried in the QRS complex is noted. So what are the implications of a third-degree AV block? Third-degree AV block may progress suddenly to ventricular standstill or asystole with little or no warning. This usually is a finding that occurs as a result of a complication of myocardial infarction, particularly inferior wall MI or anterior wall MI. Notice now that in the event that it is a complication of an inferior wall MI, it usually is stable and resolves on their own. However, if it is as a result of a complication of an anterior wall MI, it usually is unstable and may require permanent pacing. There are other causes of third-degree AV blocks, such as Lyme disease, digitalis toxicity, or degeneration of the electrical conduction system. Syncopal episodes resulting from third-degree AV block is termed Stokes-Adams attack. Because of the advanced degree of block and the decrease in heart rate, third-degree AV block is an emergency. The treatment for third-degree AV block includes external pacing, and this could be used for treatment of symptomatic complete heart block until such time that a transvenous pacemaker can be inserted. In the event that the third-degree AV block is going to be unresolved as a result of a complication of myocardial infarction or or otherwise, then the patient will require a permanent pacemaker. Similar to second-degree AV block, atropine is not going to be recommended for complete heart block, particularly if there's a wide QRS complex, because this may result in a further slowing of the ventricular rate. Third-degree AV block is an emergency, and you must learn how to recognize this particular rhythm. There are several tips that can be used to identify complete heart block. And the first one is to look for all the P waves and measure the P to P interval. This will demonstrate regularity of the P wave. And likewise, you should also measure the R to R interval. And there should be regularity of the R to R interval as well. The difference between the atrial rate and the ventricular rate is the demonstration that there is AV dissociation. Always measure the PR intervals whenever you suspect an AV block. Third-degree AV block can be identified because of the variability in the PR interval. And this variability in the PR interval may also be reflected by some P waves appearing to be swallowed by the QRS complex. An inconsistent PR interval leads to the diagnosis of a complete heart block. In summary, AV blocks are of three kinds: first-degree AV block, second-degree AV block, and third-degree AV block. The degree of the seriousness of the block depends on how much P waves are going to be non-conducted to the ventricles. In a first-degree AV block, all P waves are conducted to the ventricles, causing a QRS. The only problem is, in first-degree AV block, there is a prolongation of the conduction time, so that the PR interval is going to be more than 0.20 seconds. In a second-degree AV block, there are some P waves that are not going to be conducted to the ventricles. And there are two types: second-degree AV block type 1 and second-degree AV block type 2. In a second-degree AV block type 1, there are P waves that are not going to be conducted to the ventricles. However, the PR interval is going to be prolonged in a fashion that is going to be a prolonging pattern. So there is a gradual prolongation of the PR interval until such time that the AV node can no longer conduct the atrial impulse to the ventricles, causing a P wave to be non-conducted. In a second-degree AV block type 2, which is more of a serious AV block compared to the previous two, there's going to be a lot more P waves that are not going to be conducted into the ventricles. This results in many P waves that will not have a QRS complex. The distinct observation in a second-degree AV block type 2 is that all the P waves that are conducted to the ventricles, or all the P waves that will have a QRS complex, will have similar PR intervals. The PR intervals, therefore, in a second-degree AV block will be constant or fixed. The most serious, which is third-degree AV block, is going to be a type of block wherein there is total disassociation between atrial activity and ventricular activity. The P waves are beating independently, the QRS are beating independently, and therefore there is a total dyssynchrony between atrial depolarization and ventricular depolarization. That concludes our discussion on AV blocks.